A very good afternoon to all the seniors and all the residents. Today we are going to present a combined clinical round on, and the title is A Tale of Two Institutes Achieving Excellence. So this is a story between AIIMS Delhi and AIIMS Raipur, and it's a story of a young adult who had a successful bilateral leg replantation. So usually when we talk of replant, most common organ that comes to us is upper limb at various level, fingers, palm, hand, wrist, any level. Just a brief that what is done in a replant, whenever a amputated part is comes to us, we take it for exploration, and once we find that the part is replantable, we take it to the OT. And first the bone is fixed, then tendons, nerves, they are fixed, and then artery and veins are fixed, and finally the skin is closed. This is a diagrammatic representation of the upper limb because most common is upper limb. Dr. Subhashish will take you to a journey of a story of a young boy who had accidentally amputation of both his legs.
Thank you, sir. So, coming to the case, a 20-year-old factory worker presented to us with bilateral lower third of the leg amputated by metal hydraulic cutting machine. And the time of injury was 11:30 a.m. in the morning, and he presented to us at 3:30 p.m. in the evening. And but the amputated part was not stored properly, like we store it in cold water or ice water. So So we examined the patient. The patient was alert conscious. Primary examination was done. On the local examination, what we found, the right side leg was almost amputated, except it is attached with the tendo Achilles. The tendon Achilles tendon was only there, but it was also partially cut. On the left side, it was a total amputation of the foot. So with this injury, he presented to us. So this is the machine which the metal cutting seat machine where he has sustained the injury, and you can see it is a big machine. So we started routine investigation, blood parameters and all. We have excluded any other trauma. CT, abdomen and head was found to be normal. And the most important thing, we have done the X-ray of the bilateral leg. And what we found on the right side, there was an injury at the lower side of the leg, but there was some fracture in the other lower down also. And left side, there is total transection of the leg. So coming clinically correlating, the right leg was, you can see, it was cut at the lower third, then over the dorsum of foot also there is injury, the tendons are cut, the artery is cut, and this is the left side. So this is the workflow of our how we work, how we assess. So in the first 15 minutes, we assess the injury, we make it triage, what should be done. We send the investigation. Then sometimes we send the part to the OT without the patient being sent to OT, so that we can explore the part on table, so we can minimize the time of preparation. So in this case also, the left leg was sent earlier before the patient went to OT, and we started dissecting the limb so that we can anastomosis with the limb with the patient in a duly time manner. And this is the part we have taken already into OT. The plantation of the bilateral limb was planned, and uh, then the bone fixation was carried out. I'd like to request Dr. Uh, he's a SR from orthopedics, and he will guide us for bone fixation.
Good afternoon, everyone. I'm Dr. Namit, SR Orthopedics. So we see bones, TRS team see soft tissue, and together we see leg. And this is the beauty of this institute. And coming to this case, there was partial amputation of the right foot and complete amputation of the left foot. So on right side, there was fracture of distal end of tibia, which was going intra-articularly, And on the left side, there was fracture in the junction of distal third and mid third of both bone. So on right side, there was very little bone to reconstruct. And in this case, because there was time constraint and taking soft tissue into consideration, we decided to go ahead with external fixation. So on right side, we decided to go ahead with a delta frame external fixation by putting a single pin in calcaneum and two pins in the proximal fragment and constructing a delta frame. And on left side, we constructed a inverted T shaped external fixation with a cross pins in distal fragment and two similar pins in proximal fragment. So this was the best possible procedure that we could do so that the patient got stable bone fixation, however temporarily. So I'll pass on to Dr. Devashish.
Thank you. So after the first step was to provide a bony fixation so that we can work on that and we can provide, it will provide a stable support. So we know there are three arteries in the limb, that is anteritibial artery, posterior artery and peroneal artery. So in both the limb, we have repaired all the three arteries. Accompanying the arteries, there are vena comitatus. So we have also repaired all the vena comitatus and the tibial nerve, posterior tibial nerve, peroneal nerve, and the saphenous nerve, all are repaired. So three arteries, five veins, and three nerves in each limb. So it was a huge task, and we have repaired in the both limbs. Everything was repaired. So in the right limb, right leg, the tendo Achilles was intact. Apart from all the other structure were cut. Similarly, in the left leg, everything was cut. So the tendons, tibialis anterior, extensor hallucis longus. In the posterior compartment, tibialis posterior, flexor hallucis longus, flexor digitorum longus, everything was repaired. And after repair, this was the result. Immediate postoperative result. There are some wounds over the this leg because of multi-level injury, but that later have some problem. On the day 8, we found that this area is this skin over the wound is becoming necrotic. So what we did, we applied negative pressure dressing and we tried to create granulation tissue so that we can do a skin grafting. But it was not very good granulation tissue. So ultimately, we did another free tissue transfer from the thigh. We have put a anterolateral thigh flap over the wound. And after nearly 1 month, the patient was discharged from AIIMS. So this is the sequence of event. The injury occurred on 20 September. We presented to us 3 p.m. We replantation started, replantation over on 21st September 2 a.m. Then we did some skin grafting and again free tissue transfer. In the meantime, we have started rehabilitation of the patient so that we can have a good outcome. Only survival of replantation will not be a successful replantation. A functional replantation will be a successful replantation. That's why we have stressed upon the physiotherapy and rehabilitation part, and we discharge the patient. And the patient went to AIIMS Raipur. Due to COVID situation, he couldn't be followed in the meantime, but he's a native of Chhattisgarh, so he went to AIIMS Raipur, and they have changed the external fixator into internal nails. So I have a video clip from AIIMS Raipur. They have sent this video clip, thanks to them. So this Dr. Kar from AIIMS Raipur. So in the meantime, we have followed up the patient via teleconsultation, and regularly we asked him to send us the video how he is doing. We asked him what are the exercises he should do. So, so follow up and results. This has been almost 2 years, and the patient is able to stand, bear weight. He can extend his toes. Sensation over his two most areas are present. He can now ride a bicycle, motorcycle. So this was the after post 8 months. You can see some of the movement gradually came back after 8 months, and at 12 months you can see the extension is better compared to the previous. So from here to replantation to this, he has covered a long way, and he has sent this video a few months back. He can now able to walk. There is some little change in gait, but he is now able to bear his weight, and he can ride bicycle as well as motorcycle. So this is a very inspiring moment for the surgeons when you see a patient of such gruesome injury to leading a almost normal life, and it's inspiring. So now I would like to ask Misa, our physiotherapist. She has been following up the patient, and she will give some input.
Thank you, sir. Myself, Misha. I am from Burns and Plastic Physiotherapy team. I've been following this case on tele-rehabilitation. So for this case, the specific physiotherapy aims were to normalize the joint range of motion, especially for the joints that were below the amputation level. Second was to re-educate the patient for sensory and motor function. Third was to prevent the undesired biomechanical changes that leads to deformities and limits the patient's daily functioning. This was done by giving a proper orthosis to the patient. Fourth was to re-educate the patient and the caregiver for the limb care, special emphasis to the injury prevention to the desensate part. Once the patient was able to stand and walk, we gave him a little bit of proprioceptive training so that he is able to walk on unbalanced surfaces. Now the major challenges we faced. First and foremost the COVID pandemic that limited our direct contact with the patient. Physical touch is needed almost all the physical therapy interventions like scar massage, passive and active mobilizations, palpations and movements. So it was difficult to follow up with the patient through tele-rehab. Yet another problem was to do an assessment, how much sensory recovery was there, how much motor recovery was there, and review the exercise accordingly. When the patient was there in the department, AIIMS, admitted here, he underwent a number of surgical procedures. So basically, sir has already described all the surgical procedures. He used to have multiple surgical interventions. Throughout the interventions, we have given him various exercises. Like whenever a surgical intervention was there, after post-op day 3, 48 hours plus, we gave gentle toe movements to patient, active isometric quadricep exercises so that the knee strength can be maintained, and knee and hip range of motion exercise with a support so that the patient is able to maintain the hip and knee ranges. Then ALT flap was done, thigh muscle strengthening was done for the left side, and gentle toe movements were continued. The patient got discharged after a month. On the discharge, the patient and the caregiver was given all the advices for physiotherapy. For ankle and foot, gentle active assisted range of motion, the patient caregiver was told all the grips, where to handle and where to do the movements. Then for knee, quadriceps set exercises for strengthening and active range of motion as was permitted within the bandages. For hip, supine SLRs with support in the leg at external fixators. For the trunk, we gave a few strengthening exercises and mobility exercises, which were basically the best bed mobility exercises so that the patient is able to perform his daily activities within the bed. Patient was then referred to AIIMS Raipur. For the left foot, interlocking nailing was done. For the right foot, K-wiring was done. This data we gathered from the physiotherapist there. Strengthening exercises for hip and knee was continued throughout. After 4 weeks post-op, immediate after interlocking nailing, the patient was allowed to bear weight, but there was difficulty in bearing weight. So dynamization of screw was done and below knee cast was given. The patient was allowed to gradually bear weight with the help of an assistive device that was walker. The patient was able to walk without an assistive device, but with the use of AFO, ankle foot orthosis, in the right side within the period of time. So how the patient achieved this functional aspect? Post lower limb replant, by the 7 months, patient was able to walk with the support. A cane was given to patient. That cane was not a custom made. It was more like a lathi that was used in the rural area. After 10 months, patient was able to walk without any walking aid, but with the use of AFO on the right foot. Without the AFO, he wasn't able to walk more than 5 or 6 steps. After 11 months, the patient was cycling and stair climbing. By 14 months, patient was riding a bike. So the patient is able to walk, but some deviations. Since the range and the strength of hip and knee was complete and full, the patient was able to achieve independent walking with the use of AFO and some deviations. In the right foot, during the swing phase, the right foot, there was a drop in the right foot, and along with the drop, there was a tightness at tendo Achilles. Due to that tightness, the knee was pulled backwards and a dynamic genu recurvatum developed. Due to these problems, the patient, for the foot clearing, the patient need to attain another gait pattern deviation, which is called as high steppage gait. The patient was walking with a high step gait on the right side. So through our tele-rehab, our final conclusion and 22 months follow-up, the problems patient was facing on the right foot was a foot drop majorly and cavus deformity. This could be easily managed through a custom-made AFO, which a patient is still looking forward to, and surgery, that is triple arthrodesis, which is a secondary procedures can be done later. For the left foot, there was cavus deformity, but relatively less. The orthotic or shoe modification with metatarsal head offloading orthosis can be used. There was a limb-length discrepancy where right limb was greater than the left limb, which is approximately 2 centimeters. This is not an indication for a surgery, and through a shoe race, patient can improve his gait pattern. The physiotherapy evidences. First and foremost is the caregiver or the caretaker. His participation plays a major role in the success of patient functional recovery. Physiotherapy done adequately and on a regular basis through extended period of time provides better functional capacities. Also, the patient needs to undergo secondary procedures. So, physiotherapy may be needed for a month of 9 to 60 months with a mean of 15 months. Thank you. For review of literature, over to Dr. Archana.
Thank you, Misha. I am Dr. Archana and I will be talking briefly about review of literature. First description of a successful limb reimplant comes from 1964 when Ronald Matt and McCann muttered the courage to successfully reimplant an above elbow amputation of a upper limb into a 12-year-old child. Since then, we have come a long way, especially with the advent of advanced microsurgical techniques and the concept of muscle elementarization and intensive care such as ECMO. We are now venturing into the territory of previously non-reimplantable limbs and blurring the lines between clearly reimplantable and non-reimplantable limbs. However, there are still indications regarding which limb should be reimplanted and which should not be reimplanted based on the factors. Battison clearly describes in his article that the important factors are patient's age, ischemia time, type and extent of tissue damage, and bilateral amputations. Talking about age, Although young, healthy adults are preferable candidates for bilateral or limb reimplant, but still the evidence of bilateral leg reimplant in a 3-month-old baby has been documented. Now, the second most important factor is ischemia time. It should be around less than 6 hours, especially in the lower limb because of large bulky masses. With the ischemia time and the availability of advanced prosthesis, the incidence of bilateral lower limb reimplant is a rare occurrence even in the plastic surgery world today. And there are only a handful of cases reported in the literature. Kim Smedhammer, in his article, compares the pros and cons of bilateral lower leg reimplantation versus prosthesis. He concludes that the decision should be based on individual cases and cannot be generalized. However, he emphasizes the fact that bilateral lower leg reimplant has a positive social, psychosocial impact on the family of the patient and the patient in the society. Now, concluding that the two most important factors for a successful limb reimplant are ischemia time and part preservation. This slide shows how the amputated part should be preserved for a successful reimplant. The amputated part first should be washed thoroughly in under the tap water to remove any gross contamination. Then it should be wrapped in a moist gauze or a clean cloth, and this part should be placed in a dry plastic bag. It should not be directly placed in a ice, water, or directly over the ice. And this dry plastic bag again should be placed in another plastic bag containing ice. Now I would like to invite Manish sir for conclusion and take home message.
Thank you everyone for attending this PCR, and I must congratulate Dr. Shashank and his team. I think in the middle of night, 10 surgeons working together, the patient comes suddenly, we are not sure when the patient will come. And of course, the anesthesia team, the entire trauma center staff, and because of this COVID situation, unluckily, we are not able to do all these things. Though the patients are decreasing, but somehow this combined effort is not possible. And this particular case, because of the COVID, we somehow found a solution to, and Shaminder, the plastic surgeon, actually went from our team. So we discussed with them and they kindly agreed. I think this is the beauty of a combined institute effort, and the patient was not able to come at all. So I thought this should be presented in this particular mode rather than a surgical expertise. It is more of an interinstitutional success which we want to actually highlight on this. And then we can, Shashank, you want to add something, or then we can have questions, I think. Questions or comments? Mohit.
He shot me of the leg.
Sir, in this particular case, the amputation was at the level of distal leg. So at the level of distal leg, the remaining amputated part does not have that much muscle that we expect any kind of compartment syndrome. So compartment syndrome usually in the proximal or middle leg where the muscle bulk is there. And in this patient, on the right side, it was at the level of ankle, and the left side was at the level of distal leg. So there was no muscle that that could swell to produce a compartment syndrome. So we did not do a fasciotomy.
Thank you.
I think this is truly remarkable, and it's one thing to say that we, anastomosed 5 arteries, 3 veins, and 4 nerves, and it's actually to do it. I can't imagine how much complexity of management of the entire team. So congratulations to the entire team. This is really wonderful. The only other thing is the ischemia time was higher than more than 6 hours in this case, wasn't it?
When the patient came to us for 4 hours, so we usually immediately in the emergency, we will at least start the ischemia from that point, but starting restore in ice at least in the emergency. So it was actually 4 hours. So after that, we actually reduced the ischemia time. Sir, theoretically, people have even replanted after 12 hours, 18 hours also. It all depends that how distal it is. As it was little distal, so we were lucky enough. It was, had it been little more proximal, with more muscle mass, it was almost impossible. Fingers we have done even after 12 hours. Yeah, I think
So
Shashank can tell on.
in this patient, the right ankle on the right ankle there was double level injury. So the intervening skin had necrosis. So we did a microvascular free flap to cover that area. Yes, sir. No, sir. There was no redoing of any vessel. Yes, sir. Actually, this was case because this was a sharp cut, so that's why we did not have that much element of crush injury, so that the vessels were badly damaged. No, sir. He came before COVID, but due to COVID, he could not come for the secondary surgeries, and that's why we coordinated with the AIIMS Raipur team, the plastic surgery team, and the orthopedics team at AIIMS Raipur, and then coordinated the post-op management. Thank you.